Well, do you want to test your slides quickly? Joel, I see you're not connected via audio. Joel? You hear me? Can you hear me now, Joel? Now you're on mute.
Thanks, Graham. Yes, I can hear you.
Okay.
Sorry, man.
You want to try sharing the screen just before?
Is it sharing?
Yeah, that's fine. That's coming up fine. Okay, you can probably take it down and then we'll get going in like 2 minutes, I think.
Okay.
Okay, good afternoon, colleagues, and welcome to this week's Department of Medicine meeting. We have an invited speaker this afternoon from within our department. But before we get on to the topic for today, I just wanted to make colleagues in the department aware of the fact that it's now possible to offer SARS-CoV-2 or COVID vaccination to outpatients attending the medical outpatients. This has been arranged by hospital management and the Groote Schuur pharmacy. And I'll post in the chat function the details of how to do that. But essentially, if one identifies a patient who hasn't been vaccinated and consents to vaccination in the outpatients department, then as long as it's early enough in the morning before 10:30 to contact Sister Marceval, and I'll post the number there. And there's a consenting process. There's a team from the ICC that comes across each day and is involved in vaccination of consenting eligible patients for vaccination. Obviously, this is just starting out and there might be some teething problems, but the hope is that we will be able to offer vaccination to many patients who have not had vaccination yet, who are attending our OPD. And obviously, we need to screen them for COVID symptoms. If they've got COVID symptoms, they wouldn't be eligible. And they need to sign the informed consent. So with that message, and as I said, I'll post more details in the chat function, we move on to the main topic for today. And it's a great pleasure to introduce Joel Dave. Joel is the head of the Division of Endocrinology at UCT and Groote Schuur Hospital. And Joel's going to be speaking to us on the modern management of type 2 diabetes, fashion versus evidence. And I think we all appreciate the fact that diabetes is probably among the most important public health problems facing South Africa today. And with the increasing prevalence of the problem, it's just going to come to be one of the dominant issues in our practices as physicians in the years to come. And there've been a number of exciting developments in the treatment of the condition. And Joel's going to kind of decipher some of those for the general physician today. So really looking forward to this very important talk. And thanks, Joel.
Thank you very much, Graham, and good afternoon to everyone. And thank you for the invitation to speak on this important topic. I hope you're seeing my screen, Graham, if you can just confirm.
Yeah, the screen hearing you and the screen's in full screen mode.
Great, thanks. As Graham has said, there's been a flurry of activity in this field with many new drug classes, and many of these drug classes now also being investigated for management options in people without diabetes. And it's a massive field, and an absolutely thorough talk on everything in this field would require about 9 hours. So what I've decided to do is to restrict this talk and focus on the following statements and questions. And I never do a talk on diabetes without first emphasizing the size of the problem, because every time I talk, the size has already actually increased. And it also puts into perspective what we need to focus on when we're actually treating patients with type 2 diabetes. So just to re-emphasize the size, currently there's about 463 million people who are known to have diabetes. It's estimated to increase to about 700 million by 2045. One of the very important quoted statistics, and also here in South Africa, is that essentially about 50% of people who are currently diabetic don't actually yet know that they're diabetic, so they're undiagnosed. Also, with all the available options to us, about 70% of patients actually won't reach their optimal treatment. And we have a staggering number of deaths from diabetes annually, about 4 million. We now know that currently the deaths from SARS-CoV-2 is about 4.2 million. But in diabetes, this happens annually. And just to show you that in 2015, there were 5 million deaths. And this was more than all the deaths from HIV, TB, and malaria all put together. And consequently, obviously, with all of that, it's a huge cost. Globally estimated in 2019 to be about $760 billion. Unfortunately, Africa is not spared, and you can see that in the next 20 to 30 years, we're actually going to have the greatest increase in prevalence of diabetes on our continent. And unfortunately, South Africa, again, we're the leaders in Africa. We have about 4.6 million people with diabetes at the moment, adults with diabetes. And just to re-emphasize the commonly quoted statistic from the International Diabetes Federation is that in South Africa, it's estimated that at least 52% of people living with diabetes are currently undiagnosed. So they're diabetic now, and we haven't yet diagnosed them. Diabetes in 2016 from Stats SA was shown to be the leading cause of death in the Western Cape. It was the leading cause of death in women in South Africa. And it's the second leading cause of death in everyone in South Africa, men and women. But if you have a look at that carefully between 2014, 15, and 16, you can see that diabetes is slowly catching TB as the #1 killer. And I'm sure probably by now, 5 or 6 years later, it's probably caught TB. So what are people with diabetes dying from? Well, the major problem is cardiovascular disease. That's a major killer of people with diabetes. Yes, they're prone to the other complications of diabetes, such as renal failure, cancers, strokes. But the #1 killer in males and females and type 1 and type 2 diabetes is cardiovascular disease. So the next big question is, why should we actually even treat diabetes? Well, luckily now we have ample data from large randomized controlled trials to show that controlling glycemia, managing diabetes, we're able to prevent microvascular disease. You can see across the spectrum of the randomized controlled trials. However, in these initial studies, you can see that there was no effect on macrovascular disease, cardiovascular endpoints, or mortality. But thankfully, in the extension arms of these two landmark studies, it was finally shown that by treating hypoglycemia, one can actually finally reduce macrovascular disease as well. So we finally have data that if we treat diabetes, we are able to prevent all complications. So I just want to quickly look at the drug versus glucose effect. In all these studies that I've quoted, essentially it was all about A1C reduction, getting the A1C to a specific target, and the A1C in our landmark studies, the UK PDS and the DCCT, was shown to be 7% for your optimum reduction in complications. But what we also learned from our landmark studies, especially the UK PDS, was that for every 1% reduction in A1C, there is actually clinical benefit. Secondly, both landmark trials in diabetes, the DCCT in type 1s and the UK PDS in type 2s, actually showed something that has been termed the legacy effect. And if you can see in these studies, the intensively treated group in both studies achieved a much lower A1C, a significantly lower A1C than the conventionally treated group. However, in the extension studies, they actually then had the same A1C. And in those extension studies, it was the people in the intensive arm who then still had much better outcomes than those in the conventional arms, showing that any period of good glycemic control will translate years later in clinical benefit. So the so-called legacy effect. I know that it has been questioned because of the overlap that exists between the two arms, but it's still a term that for me brings a little bit of reprieve, because often trying to get our patients to be controlled is quite problematic. And knowing that for every 1% reduction, I get benefit, and at any time period that I could get my diabetic controlled, it actually reassures me that I'm being of some benefit to them. I also just want to highlight a very important study, the STENO2 trial. And in this study, they enrolled a spectrum of people living with type 2 diabetes and randomized them to intensive or conventional treatment. And the primary study endpoint was a composite of death from cardiovascular causes, non-fatal myocardial infarction, coronary artery bypass grafting, percutaneous coronary intervention, non-fatal stroke, amputation as a result of ischemia or vascular surgery for peripheral atherosclerotic cardiovascular, artery disease. So essentially all components of macrovascular disease. And what they did was they had a multi-factor intervention, treating multiple components to intensive targets. And in the conventional one, they treated them to target, but the targets were a little bit looser. They then also had a dietary approach where the total daily intake of fat was less than 30% of the daily energy intake, and they also limited the saturated fatty acids. And they also encouraged light to moderate exercise for at least 30 minutes, 3 to 5 times weekly. And what they showed was staggering, a massively significant drop in macrovascular disease and microvascular disease, but by a multi-factor targeting. And so when we look at the management of type 2 diabetes, we must focus on multi-factor intervention. So targeting the weight, encouraging exercise, yes, getting the A1C to target, aggressive blood pressure control, lipid control, aspirin where indicated, and encouraging no smoking. Just another study that I'm sure Brian Rayner and Dirk will enjoy is that when it comes to cardiovascular risk reduction, you get your greatest benefit first with controlling blood pressure, your next greatest benefit by controlling the LDL, and then your next greatest benefit by controlling the A1C. I know as diabetologists and endocrinologists, we become quite glucocentric, but we mustn't lose sight of the fact that probably blood pressure and LDL reduction are more important for reduction in cardiovascular disease than the A1C. So just in summary, the A1C reduction important and multi-factor intervention aiming for specific targets, but especially blood pressure and LDL. So let's look just at some of the guidelines. And just before I go into that, I want to rehash the pathogenesis of type 2 diabetes and the development of drugs. This was the thought of the pathogenesis of type 2 diabetes a few years ago, a balance between a beta cell problem and insulin resistance. And insulin resistance majorly brought about by overweight and obesity. And at that time, we had drugs. Many of you will recognize that these are essentially the drugs we still have access to in the public sector. The insulin and the sulfonylureas targeted the problem with the beta cell, and metformin was used to target the problem with insulin resistance. However, it's now become widely appreciated that that is too simple and that it's more complex, the pathophysiological processes putting people at risk of developing type 2 diabetes. And this is quite a famous slide now, the ominous octet, showing the input from various systems predisposing people to developing hyperglycemia and type 2 diabetes. And consequent on this, clearly the drug companies have hopped on this, and there's been an explosion in drugs over the last 30 or 40 years, to the point now where we have about 12 to 13 different classes of drugs that we can use to treat people with type 2 diabetes. And if we have a look at that ominous octet, we now have agents that could target all pathophysiologic processes leading to diabetes. And so we now have multiple drugs and multiple new classes of drugs, and this can clearly create anguish in the treating clinician as well as the patient. It is often quite confusing which drugs to use and in which clinical situations and at what costs. Luckily, we have multiple diabetes associations that put out guidelines, but it's these guidelines from the American Diabetes Association and the European Diabetes Association that usually pack the most punch and are mostly followed worldwide. And I think they therefore need to be quite circumspect in what they advise clinicians, because clinicians usually hang on their every word and do exactly what they recommend. And if you can see from their new guidelines, they promote upfront GLP-1 receptor agonists and SGLT2 inhibitors ahead of sulfonylureas. Okay, in contrast, if we have a look at the 2017 guidelines, type 2 diabetes guidelines from the South African Endocrine Society, they still have sulfonylureas quite prominently in the forefront of the management. These guidelines are actually currently being updated, so it's going to be interesting to see the path taken by the society. So what is the evidence being used by the ADA and ESD to put these medications ahead of some of the older drugs? And is this based on scientific evidence, or is it actually just mostly hype surrounding something new and something that is now more fashionable? Before I would get on to that, I just want to emphasize, and this is a table taken from the type 2 diabetes guidelines from the South African Endocrine Society. And I just want to emphasize that across the drug classes, essentially from an HbA1c reduction point of view, so a glycemic efficacy point of view, all agents are essentially equal. So if you have a look at all head-to-head studies, in all those studies, the ability for each drug to reduce the A1C, it was all essentially equal. So from an efficacy point of view at controlling diabetes, all drug classes are essentially equal. So then let's have a look at the GLP-1 receptor agonists and have a look at the evidence for them. And just to take one step back, and for those who haven't followed the path of these drugs, just to show that about 40 years ago now, it was shown that if you give a patient a glycemic load orally or intravenously, you get the same profile in the blood. However, if you have a look at the insulin response, there's a vastly different insulin response if you take it orally compared to if you take it intravenously. And this led very clever scientists to find that there are L cells in the intestine that when they're stimulated by glucose, they release both these molecules, GIP and GLP-1, glucagon-like peptide 1. Glucagon-like peptide 1 was actually found to be low in people with type 2 diabetes. So most of the research actually centered on this molecule. And what this molecule in vitro studies has been shown to do is that it's a potent insulin secretagogue. It goes to the pancreas and stimulates the beta cell to secrete insulin. It goes to the brain and it increases satiety and consequently decreases food intake and body weight. It's also very good at decreasing gastric emptying and thereby also helping with postprandial glucose control. And then it also has major effects on the heart, which I'll go through on a later slide. Unfortunately, as soon as GLP-1 is released, it's rapidly broken down by DPP-4 to inactive GLP-1. And so this whole system has lent itself to the development of two new classes of drugs, the GLP-1 analogs and the DPP-4 inhibitors. So these DPP-4 inhibitors bind to DPP-4 and increase the longevity of active GLP-1. So you can reap all those benefits of GLP-1 that I've already mentioned. So just to go through quickly what you can expect and what studies have shown you can expect from a glycemic point of view from the DPP-4 inhibitors. They're quite effective, as most other drugs are, at reducing A1C. They're weight neutral. They don't cause any weight gain. They result in minimal hypoglycemia. And they do have some degree of postprandial glucose control. However, it's the cardiovascular outcome trials in most of these drugs that differentiate or distinguish them from each other. And when we have a look at the four major randomized controlled trials looking at the ability to reduce cardiovascular events, you can see that from a class point of view, they are cardiovascularly safe. They don't increase events, but unfortunately, they also don't decrease events. So it's a class of drugs that is safe for the heart. If we have a look from a glycemic point of view, what you'll expect from the GLP-1 analogs, they are quite effective in reducing A1C as much as any other drug. As already mentioned, you can expect weight loss. When you read the studies, the average weight loss is somewhere between 1 and 6 kilograms. Anecdotally, if you speak to people that have been involved in these studies, you do get some patients that have major weight loss in the order of 20 to 30 kilograms. But by far and large, the average or mean weight reduction is about 3 to 4 kilos. They result in minimal hypoglycemia, and they're also quite effective at postprandial glucose control. However, it's a result of this trial, the LEADER trial, that made everyone sit up and take note of this drug class, as this was the first study to show a drug-specific effect in reducing ischemic heart disease and mortality. I emphasized previously that in all those previous randomized controlled trials, it was all dependent on getting the A1C to a target, and that there was no drug effect. This was the first trial to show that a specific drug could actually reduce ischemic heart disease and mortality. And if you have a look, the effect is small, but still significant. It was significant in reducing the primary outcome. The primary outcome was a time to event analysis of first occurrence of death from cardiovascular causes, non-fatal myocardial infarction, and non-fatal stroke. It also significantly decreased death from cardiovascular causes and also decreased death from any cause. So it caused a major hurrahs in the endocrine world, because finally a drug that could help us target the #1 killer of our patients with diabetes. I've included the latest meta-analysis because it shows the 8 large randomized controlled trials on drugs in this class. And I know this table is from the manuscript, and I know it's quite busy, but I just wanted to use it to illustrate a few important points. #1, I think it's very important that everyone gets to know the names of these drugs. They're not easy to pronounce, especially if you grew up in Milnerton, but they are here in South Africa. We have exenatide, we have dulaglutide, we have semaglutide, we have liraglutide, and we're actually getting a combination of lixisenatide and insulin coming into our market. And we're also hopefully going to be trying to motivate to get access for our public sector patients to some of these drugs. So it is, unfortunately, a drug class that all of us need to actually get to know the names. Just to also show that it's administered subcutaneously, there's only one oral form, and that is semaglutide. It comes in an oral form and a weekly subcutaneous form. And you can see here also that there's a daily injection, there's a weekly injection, and exenatide is actually, okay, it's not on this one, but there's actually an exenatide that is twice a day. Just to show you that all of these studies, the patients were over 60 years of age. Most of them were males. All of them were obese. At least 3/4 were of white ethnicity. You can see that almost all the patients had diabetes for at least 10 years. And very importantly, these are secondary prevention studies. You can see that the majority of patients in these studies already had established cardiovascular disease. So from what I've already mentioned, you can see that these studies do still leave, I think, a significant gap for the management of people living with type 2 diabetes, as it doesn't quite help us manage the patient who's under 60 or who has diabetes for less than 10 years, or who is not obese, or who does not have any pre-existing cardiovascular disease. Just to show you that the 3-point MACE If you have a look at meta-analysis systematic review, the effect size is significant. Also for cardiovascular death, for non-fatal and fatal myocardial infarction, and also fatal and non-fatal stroke, largely led by one study though, which was the REWIND study. And then also in all-cause mortality, and then also very good data coming forth on the ability to reduce macroalbuminuria and help with diabetic nephropathy and progression to end-stage renal disease. And why should these drugs have such a major effect on the cardiovascular system? Well, you can see from this that what studies have shown is that they have a direct action on the myocardium. They also have a direct action on the vasculature. I'm not going to go through each function, but suffice to say that you can see that they're largely anti-atherosclerotic, and they also pro-myocardial improvement in myocardial function. So significant benefits of these drugs on the cardiovascular system. And just to show you the pipeline, we've already got once daily, twice daily, and once weekly. They're currently also now working on once a month. So that would be a fantastic achievement, especially for our non-compliant patients, if they could take a drug once a month that would be able to help them control their diabetes. Let's then go on to the SGLT2 inhibitors and see what the evidence is for that. Again, just for those that haven't been following it, and I'm sure everyone on this call knows this, that the majority of glucose, in fact, all glucose is reabsorbed proximally, most of it by SGLT2, some of it by SGLT1, such that in the filtrate, in the urine, there's no glucose. And we've always been brought up as medical students and registrars to believe that having glucose in the urine is actually a bad thing. But there is a genetic experiment that was done for us, which was, I think, familial renal glycosuria, where there's a natural mutation in SGLT2. And these people leak glucose all the time in their urine, and it's a completely benign disease. They don't have an increased risk of infections. They don't have an increased risk of hydronephrosis of the kidney, and they don't have fluid and volume problems. So benign condition. So if we have a look in healthy individuals, everyone knows this, you filter 180 grams of glucose a day, and all your glucose is reabsorbed. If you have a look in someone who's got hyperglycemia, so that's sort of pre-diabetes or early diabetes, you can see that it now exceeds the threshold. And I just want you to note that 3 blue glucose molecules were appeared in the urine. So you exceed the threshold for reabsorption, and you now can detect glucose in the urine. However, very interestingly, in poorly controlled diabetes, what happens is you get upregulation of SGLT2, such that you actually get, although you're getting glucose in the urine, you're getting a reduction of glucose appearing in the urine. So you're still filtering, and I just want you to notice that now only 1 glucose molecule appears in the urine. So in these patients, all the patients with poorly controlled diabetes, they're actually reabsorbing more glucose than they actually should be. So therefore, blocking or inhibiting the SGLT2 makes sense to some degree. And what the studies have shown is that you can expect a similar HbA1c reduction to many of the other agents. You can expect a weight loss in the order of 2 to 4 kilograms. This drug class is also associated with minimal hypoglycemia. And interestingly, from a side effect point of view, there's no increased risk of urinary tract infection or hypovolemia. However, in predisposed patients, so patients already who have a history of mycotic genital infections, there is actually a risk of mycotic genital infections in these patients. However, again, it was this study that brought major focus onto this class of drugs, as it was the first study. This study was actually even before the LEADER trial. to show a drug-specific cardiovascular benefit in people with type 2 diabetes. I'm just going to show the 3 randomized controlled trials with EMPA-REG was with empagliflozin, the CANVAS trial was with canagliflozin, and the dapagliflozin was with dapagliflozin. And just to show here again, this is a secondary prevention studies. All patients had established cardiovascular disease. You can see here, the majority of them had cardiovascular disease. The one study where it didn't have the majority with pre-existing cardiovascular disease, you can see that's the only study that actually didn't have a significant reduction in 3-point MACE. But you can see clearly that the EMPA-REG probably was the most successful study, showing a reduction in the primary outcome, which was 3-point MACE, a reduction in cardiovascular death and all-cause mortality, and also a very significant reduction in heart failure. What I do want to emphasize, and I've taken tables from the studies, is that, because it's often bandied about that these drugs can also have an effect on atherosclerotic cardiovascular disease. But if you have a look, you can see here that this is the CANVAS trial on canagliflozin. Canagliflozin. You can see that it had no significant benefit in any ischemic component. So any atherosclerotic component, it had no significant benefit. And the same with the EMPA-REG. So all the cardiovascular outcomes were largely driven by its very good effect on the reduction in hospitalization for heart failure and the reduction in death, essentially from heart failure. No significant reduction in any ischemic component of cardiovascular disease or stroke. And why should this be? And there's been bandied about a lot of potential mechanisms for the beneficial effect of the SGLT2 inhibitors and cardiovascular function, including metabolic effects and non-metabolic effects. I think it's probably a contribution from all of these mentioned. There's been no one effect shown that SGLT2 has on its ability to help in heart failure. And it's essentially a drug class effect. So I've made this slide summarizing all of the randomized controlled trials in the diabetes studies, focusing on all the very important components that we need to think about when managing people with diabetes, and all the drug classes over here. I just want to highlight here also that the SGLT2 inhibitors have also now been shown to be very good in the treatment of heart failure with a reduced ejection fraction, empagliflozin and dapagliflozin, and also reducing treating heart failure with preserved ejection fraction, to the point now where it's a debate as to whether an SGLT2 inhibitor is actually a diabetic drug or a drug for cardiac failure. Be that as it may, it is very good in the setting of diabetes, and also very important data showing its great benefit in the CANVAS trial and the EMPA-REG trial in reducing microalbuminuria, macroalbuminuria, and progression to end-stage renal disease. I just want to focus on the forgotten ones on the block, the sulfonylureas, and just to show you that we do have large randomized controlled trials showing in the advance for glycoside and the UK-PDS for some of the older sulfonylureas and insulin that we can reduce nephropathy. The UK-PDS, I hope I showed you that you got a myocardial infarction benefit and also a reduction in mortality. And the advanced trial with glycoside, long-acting glycoside, showed that it was cardiovascularly safe. So I think as much data with the sulfonylureas across the spectrum as with many of the other drug classes. So I hope thus far I've managed to show you and convince you that we have some great new drugs with some great results, and many of these are now available in South Africa, or they will be available soon. So what then is the problem? And I'm going to use the next slide to illustrate possibly what the problem may be. I hope none of you recognize any of this in the slide. This is actually a hotel room. It's on a submarine in St. Lucia. It's called the Lover's Deep Luxury Submarine. And this will set you back $150,000 per night. Many of you might notice this car. It's a Bugatti, the most expensive car in the world. And this will set you back $18.6 million. This, Dr. Bill Toot recognized as saffron, one of the most expensive foodstuffs in the world. It goes at about 82,000 Rand per kilogram. And the most expensive caviar ever sold was about $34,500 per kilogram. This is the most expensive suit. It's an Alexander Amosu Vanquish bespoke suit. Believe it or not, this suit will set you back $91,000. And lastly, this is the most expensive purse in the world. It's a Moed 1001 Knights Diamond purse, and it sells for $3.8 million. So this just brings us on to the cost of these agents. And if we take the LEADER trial, which I think is the leader in the GLP-1 receptor agonist arena, and we have a look what it's going to cost us to achieve the outcomes that they did in the LEADER trial. And so this cost is to prevent one event over 3 years. So you can see that to prevent one myocardial infarction is going to cost 7.5 million Rand over 3 years. A little bit better if we have a look at the EMPA-REG trial. And I've used the cost, by the way, I've used the cost of these drugs about a year or two ago. So they're likely to be even more expensive now. There hasn't been a price cut in these drugs. And you can see, although it's better, still to achieve the results from the EMPA-REG trial will cost a lot of money. And putting it into perspective with the numbers of patients that we have to treat and the cost, you can see that unfortunately, it then becomes extremely expensive and reasonably unaffordable for us in the public sector, and or for that matter in the private sector. And if you have a look at now in the data, at a time when we're already fighting compliance problems in our patients with diabetes, and we see it sort of happening in the private sector, where patients are now beginning to ration their medications, undercut the doses, the doctor says, in order to prolong the lasting of their medication so that they don't have to make as much co-payments. It's a major problem, increasing compliance issues across the world, the cost of drugs. And in the world's largest economy, there are problems of getting access to essential drugs in the lay press, and here also in high impact factor journals showing the major problem in the US with access to insulin, but also with access to other quite more expensive drugs. So I just want to end off by discussing this meta-analysis published in the Lancet Diabetes and Endocrinology in May last year. I thought it was a very well-conducted meta-analysis that then provides us with our most robust scientific evidence. And I think often with a plethora of studies available to us, and there's a new style aggressive marketing strategies by big pharma, it often makes it difficult for us to see the light at the end of the tunnel. And I think it's well-conducted studies such as this that can put it all in perspective. And I know this is busy, but it illustrates the point that I want to try and make. And I've outlined all the studies here for the thiazolidinediones. These are all studies that incorporated intensive control as an outcome measure. These are all the GLP-1 analogs and the SGLT2 inhibitors. And if we have a look here, we just draw a line through what we can expect with each strategy, the final effect size. You can see that targeting intensive glucose control is as effective as using a specific drug such as a GLP-1 analog and a specific drug such as an SGLT2 inhibitor. Also, just focusing on the weight reductions that are expected from the GLP-1 receptor agonists and SGLT2 inhibitors, because it's often difficult to gain perspective because you hear a wide spectrum of weight losses being suggested. You can see here that the weight change absolute ranges from about, let's say, 1 kilogram to about 6 kilograms. So it's variable, but no one gained weight, but you can expect up to 6 kilograms of weight loss. And here in the SGLT2 inhibitor class, you can probably expect up to 4 kilograms in weight loss. So if we then put it all together, in a patient with type 2 diabetes who has established cardiovascular disease, I think the foundation of these patients is ensuring that all of them are on a statin, all of them are on aspirin, they have adequate blood pressure control, they have adequate LDL control to a specific target, they've had weight loss encouraged, they've stopped smoking, and they're actually compliant on their medication. And then one has to then weigh up the balance between the cost efficacy of using a specific diabetes drug, such as a GLP-1 receptor analog or an SGLT2 inhibitor, to gain some extra benefit, or just a intensive control lowering A1C strategy with the cheapest drugs accessible to you. If we have a patient with no cardiovascular disease, and especially for those less than 60 or not obese, I think we have lots of data to show that a multi-factor intervention is our best approach, rather than just focusing on one specific drug to try and achieve everything. We need to chase the A1C to target, get the LDL to target, the blood pressure to target, encourage at least a 5 to 10% weight reduction, encourage exercise, and getting our patients not to smoke. So if I end off by basically showing these guidelines set forth by the American Diabetes Association, the European Diabetes Association, encouraging these very expensive strategies up front that we certainly can't afford at current day prices, but also having a look at the literature in our world's top economy who probably can't afford these either. By the way, these are probably more expensive than insulin. I find it a major problem, and I'm going to be a little bit provocative, and I've changed this around with a bit of photoshopping and said that perhaps this should be the paradigm of treatment, and that for routine HbA1c reduction needed, sulfonylureas are still adequate. We have lots of data, and they as effective in HbA1c reduction as any other agent. If there is a compelling need to minimize weight gain or hypoglycemia, then one can weigh up the cost efficacy of using an SGLT2 inhibitor or GLP-1 receptor agonist. So for example, if your patient on a sulfonylurea is having multiple admissions to an emergency unit for hypoglycemia, then one perhaps could justify the cost of using one of these drugs rather to prevent those recurrent admissions or recurrent presentations to an emergency unit. And then I would change it and say, basically, if cost is not an issue, then you consider this strategy because it's an exceptionally expensive strategy. However, that being said, there is actually a place for everything. And in this new world of individualized therapy, having access to an armamentarium of drugs makes it much better for us to actually individualize therapy, because there are going to be individuals who would do much better on a specific agent. Dr. Toot related a story to me yesterday of a patient that he had very difficult to control on any other agent, put him on an SGLT2 inhibitor, and he had wonderful control. So there's no doubt that there is a place for using these drugs in an individualized capacity. So then in summary, you can get a significant decrease in cardiovascular disease just with HbA1c reduction. Multi-factor intervention is important to reduce cardiovascular disease. I think there's good data. It's not just fashion. There's very good data now to show that the GLP-1 analogs and the SGLT2 inhibitors are effective in reducing certain types of cardiovascular endpoints and very good in setting of diabetes-related kidney disease. The additional benefit from the type of drug used added onto the aggressive management of LDL, blood pressure, weight reduction, ending smoking, exercise, I think still has to be shown. It's very important for us to individualize therapy. And I think I can talk for myself. I've been quite lazy advocating for cheaper medication for our patients. But I think we need to really do this because even though I think these drug classes are not for the masses, there's certainly quite a few individuals within the public sector that could do better on some of these agents. So it's very important that we all become advocates for better access for cheaper drugs for our patients. So thank you very much for listening, and I hope there's some questions.
Great. Thanks so much, Joel, for a really excellent overview. Very clear and a great update on the data and some of the mechanisms behind these new options and insights into where they might fit within our armamentarium going forward. So I want to encourage questions. Just to say, I just want to mute somebody there, that you can either raise your hand or type them in the chat. I think there's already one hand up and then one in the chat. So maybe Mark Sundrup, if you want to ask the first question.
Joel, that was fantastic. Thank you. I have two questions. The first one is just maybe clear my head here, because I don't know if I'm being a bit simplistic, but the cost issue aside, which is not even debatable, the newer classes of therapies are very expensive. You showed a slide on following those wonderful examples of Saffron and the car and the Bugatti, the actual cost and the numbers needed to treat. And it was based on numbers needed to treat, for example, preventing one myocardial infarction. Okay. Surely with diabetes, given the systemic nature of things, should we not be looking at the benefit an individual gets overall in terms of the cardiovascular benefit, the renal benefit, et cetera, et cetera? So it's not just based on MI risk. Should it not be a composite risk benefit? And then maybe the cost effectiveness actually starts looking a bit better. I don't fully understand that. The second question I have for you is going to be a very parochial one, and I do apologize in advance. But an issue that is quite apparent is that, I mean, you're well aware the role diabetes and insulin resistance plays in the risk for MAFLD and the growing, in fact, global burden of non-alcoholic fatty liver disease with progressive liver disease, which we are seeing in our own backyard as well. You're not seeing that in any of the diabetic guidelines anywhere in South Africa, on the African continent, and in fact, globally. Is this something that is being spoken about in diabetological circles? Is it something that we're looking at, including in guidance down the line? Thank you very much. Thank you again for a great talk.
Thanks, Mark. Thanks for those great questions. And I think you're right. I think the problem in our setting is that we don't have any very effective and major cost efficacy studies. So I agree with you. I took the one focus on cardiovascular endpoints But if you can use one drug to achieve multiple significant endpoints, then doesn't it then become cost effective? And possibly it could. And the drug I think that may become most effective are the SGLT2 inhibitors, because if you have a look at their effect on reducing microalbuminuria, macroalbuminuria, and progression to end-stage renal disease, we know that in our setting, there's severe limitation of access to dialysis. We know that diabetics over 50 are not accepted onto the program. So clearly, if we are able to delay, prevent progression of diabetic nephropathy and end-stage renal disease, we're making a significant impact on our patients' lives. But we need the health economics people to cost this out for us and to show us exactly how cost-effective a strategy with an SGLT2 inhibitor-led HbA1c reduction plus an ACE inhibitor or an ARB versus a sulfonylurea. We've got very good data from the advanced study that we can achieve very good renal endpoints with long-acting glycoside. Just to say, long-acting glycoside we could get for about 60 Rand a month. Currently, the SGLT2 inhibitor, this is in the private sector, the SGLT2 inhibitors are anywhere between 300 and 500 Rand a month, so 6 times. So we need these cost efficacy studies to be done on composite endpoints to show us if it actually is truly cost effective. I agree with you. Your second point on MAFLD, this is what I've been saying to you. I've been encouraging you to join forces with me and have a look at this in our setting. I don't think it is being looked at enough, especially in South African diabetics, but in the diabetes world, it is up and coming. And especially also, Graham will know, in the HIV world and the metabolic complications of antiretrovirals and HIV in MAFLD is increasing. So I think it hasn't gained as much respect as it should yet, but it is increasing. There are more and more talks at diabetic conferences on distribution of fat in the body, including in the liver, but not enough yet. And it's something that our two divisions need to definitely embark on.
Thanks. So Joel, just to pick up on that issue of the costing, obviously there's the broad costing of using it broadly, using them broadly in patients with diabetes versus defining subgroups that are likely to benefit the most. And just interested if you had a group of patients with diabetes and established ischemic heart disease, and surely they would benefit more from a GLP-1 agonist, and the cost effectiveness that might be more warranted in that situation.
So I agree, Graham. So if someone has a atherosclerotic basis to their cardiovascular disease, so a myocardial infarct, then using a GLP-1 is much more effective than using any other drug that we've been shown, and you're likely to get a drug effect on the course of that disease. But if we use the numbers needed to treat from the LEADER trial, to get that effect, we have to treat, we have to spend 7.5 million Rand over 3 years to prevent one event. Okay. You see the problem with, and that's liraglutide, Victoza. It's the last price that I knew, and I think it's slightly more now, was about 1,800 to 2,000 Rand a month. That's the problem. So we need to try and get, if it was a lot cheaper, I think it would be a no-brainer that we should be using that much more widely spread. And it would be nice for our health economics colleagues to do the numbers and to show us at what level, at what price does it then become economically viable for us on a larger scale to actually start using those drugs to achieve the outcomes that they did in the LEADER trial.
Yeah. Okay, I'm actually going to go to Mark Blockman next, and I'm sure Mark will have some points to make on the issues around the drugs and access.
Mark will just say no access.
He sometimes surprises you.
No. So Yeah, so I think this is very complex, and the reason it's complex because the disease itself is complex, and there are bits and pieces of it that you may want to deal with. So you may want to improve from a myocardial point of view if people have heart failure and if they have renal disease. I think that's very hard if you're looking at a policy process to try and establish that and have bits and pieces of the way you're going to manage patients. For me, the way to do this is to look holistically at the disease itself. It's an easier way of doing it, despite the fact we don't have a threshold of cost efficiency within our environment. And they usually say dialysis is one to look at, but unfortunately, dialysis is not available to everybody, so it's not a good yardstick. So for me, what one should do is you need to sit down at the table. You need to look at what the incremental cost effectiveness is. And what that means is that how much benefit are you actually going to achieve for the money you spend? And that may come out to be a reasonable amount of money. But Joel, your most telling slide, which is harmful, is the burden of disease. And once you show the burden of disease, the affordability issue becomes very important. So yes, it's easy in our environment, and we've done that before, to target say, for example, a very difficult patient to manage with heart failure and diabetes, and say they've come into hospital 3 or 4 times, let's try an SGLT2 inhibitor in that patient. And it's easy to do that. But it's much more difficult when you're looking at affordability on a greater scale. So for me, it comes down to what is the true effect size and the incremental benefit. And I think that hasn't been, when you not cherry pick, but when you look at various outcomes, it makes it much more difficult. I think we need to look at it holistically and then come down to what kind of benefit would we be looking for. And then the advocacy around bringing the cost of the medicine down so that it becomes more affordable for the population you use. I'll stop now. The problem that we have in South Africa is that we are reference priced. And so the private sector is SEP, which is not an issue. The public sector sits within a basket of various countries and that. And the fear for the multinational companies is to reduce the price to a point where they're not competitive in other countries. So advocacy, as Joel suggests, is very important to overcome that. I think the trick we're missing is not in diabetes with SGLT2 inhibitors, is in heart failure. And I think that if you truly wanted to look at the value of an SGLT2 inhibitor, it may be in patients with heart failure and low ejection fractions who've come into hospital on a regular basis, because the next best is a combination agent, which is very expensive, looking at an ARB and one of the other inhibitors of the renin-angiotensin system. And I think that may be somewhere which detracts from you, Joel, but you did mention heart failure as being an important environment. And so I think that's where one could be looking at the SGLT inhibitors in our population and the other agents in diabetes. Thank you.
Thanks, Mark.
Thanks very much for those comments, Mark. And I agree, unfortunately, one can't ignore, one wants to, in order to get access, but one can't ignore the burden of disease. And that's why I always start the talks off of the burden of disease, because it puts everything that follows in perspective. When you've got such vast numbers that you're needing to treat, it's just completely unaffordable if medications are above a certain price. But look, we're grateful at Groote Schuur that we have access on a named patient basis for individualized care. Unfortunately, other centers in the country don't really have access to that. So somehow we do need to try and work out some type of strategy where we can get certain types of medicines for certain types of patients on a national scale, rather than just here local scale at Groote Schuur Hospital. It is difficult, and we need those studies that you've suggested being done by all our health fundis who can tell us the incremental cost efficiency and cost efficacy, and other qualities and how much for quali and what's cost effective.
Graham, can I make one more point, if that's okay?
Yeah, briefly.
Just very quickly, the country is looking at an HTA, it's a health technology assessment. There's a robust discussion, and a group of colleagues at a national level are looking at a proper mechanism around HTA, health technology assessment, with pharmacoeconomics and cost efficiency, as well as the science, putting this all together, the Cochrane Center. So I think on the horizon, we will be better at making choices from an economic point of view going forward. Thank you for that.
Thanks, Mark. So Joel, we've reached the hour, but there was one early question that I just wanted to go back to. If you can just give us a brief answer to that, and then we'll wrap up. Would you recommend bariatric surgery for intractable weight gain when using these agents?
So Graham, our most effective strategy at controlling diabetes, hypertension, and losing weight in a sustainable weight is bariatric surgery, now also called metabolic surgery. So yes, and there's often debates at diabetes conferences whether metabolic surgery is the cure for type 2 diabetes. I think certainly it's not the cure for everyone with diabetes, but there's no doubt that in people with BMIs, especially over 40 or BMIs over 35 with severe comorbidity, having a look at metabolic surgery is paramount. I just wanted to bring up one, just before we go quickly, something that Pico put in the chat group, saying that we also have to look at the cost of not treating. I agree with that 100%. Often that's not looked at. And what the cost that person would cost the system by actually not treating what they've got. So I think those are all very important points.
Okay. So Joel, just to say, thanks very much again. I think this is an important issue that we should discuss again, perhaps in a year's time, as these agents become more widely available and more data emerges, specifically focusing on which patients are most likely to benefit and how we can go about, advocating for access and what's required to advocate for access for them to these new agents. Just to say, I think it's been a really great session. There was up to 91 attendees at one stage, just showing the importance and the interest in this topic. And I think to finish off with, I'll just quote Buyelwa in the chat, who says, "Thank you, Prof, for being an advocate for people living with diabetes and for promoting simple approaches to effective, affordable diabetes management." And that's a good point to end the session on. Thanks, Joel.
Thanks, Buyelwa. In course. Thank you.